You're 16, in your grandmother's kitchen, sorting her pills into a plastic organizer and holding a thermometer under her tongue. Her fever breaks by morning, and she tells your mother you've got the touch. 10 years later, you're pushing propofol in an operating room for a mean of $223,210 a year. The class that puts you on the bottom rung costs $1,500. The first paycheck clears at about $15 an hour. Between the pill organizer and the anesthesia machine sits 6 rungs, and the better part of a decade. The person holding your airway on the table may have started by emptying bedpans. This is every level of a nurse's career in America and what it actually costs to climb. If you like breakdowns of how careers actually progress, like and subscribe so you don't miss the next one. Level 1. The Caregiver. You're 16 and there's no badge, no paycheck, no title. Just your grandmother, a pill organizer, and a thermometer that beeps under her tongue. You wrap the home blood pressure cuff around her arm, pump the bulb, and watch the needle fall. The first time, you leave it too loose. The number reads low, and you learn to snug it against the skin. You write the reading on a notepad on the counter, because that's what the visiting nurse told you to do. This is what vitals are, though nobody has called them that yet. You crush half a tablet into applesauce so she'll take it. You steady her elbow on the walk from the chair to the bathroom, and you feel exactly how much of her weight is now yours to hold. Then it's quiet again. At school, they roll in a rescue mannequin and hand you a card that says you passed if you can keep a beat. You kneel, stack the heel of one hand on the sternum, and push 30 compressions, 2 breaths, check for the chest to rise. You press too shallow, and the mannequin's light stays red. You drop your shoulders over your hands, lock your elbows, and the light turns green at 100 to 120 a minute. The teacher watches once and moves on, which is its own kind of pass. You stop asking your mother which pill is which. At home, your grandmother's blood pressure comes down over a week, and she tells the visiting nurse that you have got steady hands. You keep a box of bandages in your backpack now, the way other kids keep gum. None of this pays. All of it counts. The visiting nurse mentions the hospital nearby is hiring nursing assistants. No degree, only a class. The class costs money you do not have, so you go find out how. Level 2 is the first rung with a paycheck on it. Level 2. The nursing assistant. The class costs you $1,500. The job it unlocks pays a median of $39,530 a year. Around your neck is the one thing you bought new, a Littmann stethoscope. You take blood pressures by hand here. No machine to do it for you. Your shift is a round, and the round never really ends. A call light blinks, and you answer it. You buckle a gait belt around a resident's waist, brace your knees, and walk him from the bed to the chair without letting him fold. You empty a Foley bag, measure what's in it, and chart the number, because intake and output is a figure somebody upstairs actually reads. You reposition every resident who can't move himself. Turn every 2 hours, the same clock, all night, so the skin over the hip doesn't break down. When 2 of you can't lift a total care patient, you bring in the Hoyer lift and run the sling under him together. Somebody calls a code brown down the hall, the job's blunt name for the least glamorous part of it, and you go, because that's the job. You clock the smell the first week. You stop counting residents by room number and start counting them by name. The weight of a turn lives in your lower back by the end of a shift. You learn to bend at the knees before your back learns it for you. A resident who wouldn't look at you on Monday asks for you by name on Friday. An aide at a nursing home in Worcester, Massachusetts put it plainly to a reporter. "We do the hardest job," she said, "and we are the ones closer to the residents. Your first paycheck clears." It is not much. The bottom of this rung sits near $15 an hour. But it is yours, and it is the first one. The floor supervisor watches you catch a resident's fever before the thermometer confirms it and tells you you'd make a good nurse. Not a nursing assistant. A nurse. Level 3 is where you take it. Level 3, the registered nurse. Before the badge changes, there is the exam, the one gate every nurse in America walks through. You sit in a testing center, and the screen serves one question at a time, and it decides when to stop based on whether you are passing. It can end early or run long, and either way you do not know which way it went when you stand up. The first-time pass rate was 91.2%. You wait for the result. The screen says, pass. Now the badge reads registered nurse, and the pay steps up to a median of $93,600 a year. You start on a medical surgical floor, And in California, a law called Assembly Bill 394, in force since 2004, caps how many patients they can hand you at once. The whiteboard at the station says 5. You carry 5 patients. Upstairs in the intensive care unit, a nurse carries 2. You carry a brain sheet, a folded page in your pocket with all 5 patients on it, their meds, their drips, their numbers. You cannot hold 5 people in your head at once, and nobody sane tries. You pull medications from the Pyxis, the cabinet that logs every dose to your name. You chart everything in Epic, because if it is not in Epic, it did not happen. You thread an 18-gauge IV into the crook of an elbow on the first stick and tape it down. You prime an Alaris pump to run the antibiotic over the hour. You give report in SBAR, the 4-part handoff that keeps the next nurse from missing what you saw. Then on a Tuesday, one of your 5 starts circling the drain. His blood pressure drifts down, his heart rate climbs to cover it, and the pulse reading keeps sliding no matter how you sit him up. You call the doctor and give it straight. This patient, this history, these vitals. I need eyes now. You hit the button for a rapid response, and the room fills. More hands, the crash cart, the charge nurse. You push fluids wide open, hang the drip the doctor orders, and watch the pressure claw back up. The monitor stops sliding. Then it climbs. He is still there in the morning, breathing on his own, because you caught it an hour before it would have caught him. That hour is the difference between a floor nurse and a warm body in scrubs, and it is the hour they do not teach you in school. You stop eating lunch sitting down. A new grad nurse named Rachel Dapper was hired into a Southern California hospital system called Memorial Care. She described the first months honestly, that starting fresh out of school felt daunting, but the new grad program eased the transition. Daunting is the right word. The floor either makes you or it empties you out, and it does not take long to find out which. You get faster, and your report gets tighter. The doctors start taking your call at face value, which is a promotion nobody writes down. And the whole time the unit upstairs, the one with 2 patients a nurse, is where the real money and the real skill live. Level 4 is the door-marked intensive care. Level 4, the ICU Nurse. 2 patients now, not 5, because in the intensive care unit 2 is all one nurse can safely hold when both of them are trying to die. Your day is a wall of alarms, and you learn which ones mean nothing and which one means everything. You titrate a vasoactive drip up and down by the microgram, chasing a blood pressure that will not sit still. You read an arterial line that gives you a pressure with every single heartbeat, not once every few minutes. You manage a ventilator breathing for a patient who cannot, and you watch the numbers it throws back at you. When a kidney quits, you run a bedside machine that filters the blood the kidneys cannot clean anymore, all shift long. Then a monitor flatlines and someone calls a code blue. You are the one who started the clock. You start compressions, someone bags the airway, you push EPI on the mark, and read the rhythm between rounds. The rhythm comes back on the screen. You get him to the point where the machine and the medicine can hold him, and you hand off to the next team with a pulse. Then the room empties out around you. That is the call you get paid for, not the drips, the judgment. The night alarms do not jolt you awake anymore. You wake before the shift does, and the unit is already yours. An intensive care nurse named Melody works in Arizona. She said the quiet part out loud. You feel the stress of it every single day. The stress is also the market. The staffing report covers hundreds of hospitals across dozens of states, and it puts annual nurse turnover at 16.4%. These units are always short, always hiring, always paying to keep you. During the pandemic, that math went vertical. A staff nurse pulling $1,400 a week watched travelers fly in for the same shift at $10,000 a week. Same ventilator, same code, a check that made hers look like a tip. You do not leave to travel, you have a longer game. Every nurse anesthesia program in the country wants exactly what you have right now, years of this. Drips and vents and lines, high acuity time nobody can fake. The next rung is not a floor or a unit. It is a classroom you have to be invited into, and most people who apply do not get in. Level 5 is the one that takes almost no one. Level 5. The student nurse anesthetist. This is the rung most people never reach, because the door barely opens. Across nurse anesthesia programs, the average acceptance rate is 24%, and at the tightest schools, far lower. You get in, then you find out what getting in costs. You stop working, because the program is full-time and clinical and there is no room for a paycheck beside it. For 3 years, no income comes in. The average in-state tuition across the 147 programs tracked by the CRNA Club runs $117,749. You borrow it, you watch the balance climb while your income sits at zero, and then you walk into the operating room on the other side of the drape for the first time. You learn the induction, the sequence that puts a person under and keeps them alive while they are there. You assess the airway before you touch a drug, mouth open, neck back, how hard this tube is going to be. You pre-oxygenate, hold the mask sealed to the face, and watch the chest rise on your breath, not theirs. You push the induction dose, weight-based, calculated to the kilogram. You slide the glide scope in, find the cords on the screen, and pass the tube between them. The first time, you miss, the tube goes nowhere, and the clock is loud. Your preceptor takes the blade, gets it on the first pass, and hands it back without a word. Do it again. You do it again, it goes in. You watch the little cloud fog the tube with every breath, which is how you know you are in the trachea and not the stomach. You stop reaching for the blade twice. You log every case on the anesthesia record, the one document that only exists at this altitude, every drug and dose and vital in your own hand. A student named Danae Dinoto reached her 3rd year at the University at Buffalo with 4 years of intensive care time behind her. She put the whole gamble in one line: "Through all the craziness, I know I made the right decision beginning a nurse anesthesia program." 3 years, no income, a mountain of debt, and a skill almost no one has. The last thing standing between you and the top rung is one exam. Level 6 is where the debt turns into the paycheck. Level 6. The nurse-anestetist. First, there's the last exam, the national certification exam run by the board, the NBCRNA, that licenses every nurse anesthetist in the country. In 2025, the first-time pass rate was 90.5%. You pass. The badge changes one more time to certified registered nurse anesthetist, and the pay is finally the reason you climbed. The government's own number puts the mean at $223,210 a year. The profession's own survey, the 2024 compensation survey run by the Anesthetists Association, puts the median at $251,000. Now you run the room. In a full practice state, you run the whole anesthetic yourself, start to finish, no one else at the head of the table. You push propofol, and the patient is under in one breath. You push rocuronium, and the muscles go still enough to pass the tube. You keep the depth on target, a bispectral index of 50, deep enough to feel nothing, light enough to wake up. You place a nerve block under ultrasound, so the pain is handled before the patient ever feels it. You watch the anesthesia machine breathe for them, and you hold the whole physiology in your hands for hours without looking away. Then you bring them back. You cut the gas, let the drugs wear off, watch the breathing come back on its own, and pull the tube while the monitor holds steady. You wheel them to recovery and hand off. Awake, stable, alive. The room is quiet now. A nurse anesthetist named Bruce Schoeneboom went on to teach at Johns Hopkins. He never softened what the job is. The operating room can be a very risky place, and the stakes are high. You stop rehearsing the emergency in your head. Your hands already know it. The credential now requires a doctorate, phased in by 2025, so the newest ones arrive already called doctor. You're the top of the nursing ladder, and there's no rung above this one. Here's the part nobody tells the 16-year-old with the pill organizer. At the top of the ladder you just climbed, you pause at the head of the table. You make a median of $251,000. The anesthesiologist across the same table, running the same kind of case, makes a median of $437,250. Same airway, same patient, same risk. Different letters after the name. You did the same years in the intensive care unit. You put the same tube in the same trachea. And you're fine with it, because you remember what the bottom of this ladder paid. The class that started all of it still costs $1,500. Somewhere right now, a nursing assistant is signing up for it, taking blood pressures by hand, turning a patient every 2 hours for about $15 an hour. That was you. Somewhere on a medical surgical floor, a brand new nurse is carrying 5 patients in a brain sheet, sweating the first med pass, cup trembling on the cart, the way you did. Nobody skips a rung on this ladder. The airway you hold at the top is only safe because of every bed you turned at the bottom. The Littmann stethoscope you bought as an aid, the one thing you owned new, still hangs around your neck in the operating room. It's the only tool that climbed every rung with you, from the nursing home hallway to the head of the table. There was one, early on, you couldn't bring back before you knew what you know now. You carry it, and it's the reason your hands are steady when the room goes quiet. You still take call, and you still get the middle-of-the-night case, the airway nobody else wants. But the thing that terrified you as a student, the miss, the clock, the empty tube, doesn't anymore. Your hands know it before your head does. The operating room you first entered on the far side of the drape, the one that terrified you, is the one you walk into every morning now. It's yours. You clip the stethoscope on, push the door, and the first case of the day is already on the table.